Welcome to SEVA VentRounds. And today it's going to be an interesting case that we are doing all the way from Mexico. We had this case sent to us by Dr. Andrea Carrera Ruggiero, and I'll show it to you. And I think that it will be a good teaching of how to read when nothing seems to make sense. So the title of this is absolutely no synchrony. Disclosures, no endorsements of any mode, manufacturer or company. And whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And here are disclosures for Rob and myself. And we both are directors of the course, the SEVA course, which is another conflict of interest. The ground rules, this is a recorded session, so keep your microphone muted. The moderator, I may call upon members of the audience to comment. However, you can use the chat function at any time. I'm monitoring it on the side for whatever comments you may have, but otherwise just unmute yourself and make a question as it comes. There is CRCE and CMEs for people that are interested on them. If you are a respiratory therapist, you will look at your name on the chat to be sure that you're there, and then there's an evaluation to be completed within an hour. So with no further ado, let's get started with this event that we had, and I'm putting it out in front of you so that you can take a look rapidly. You can see the shadow of Andy taking a picture of the event. And so let's start with, what do we feel the tag is? I'll give you a second to think through it and see in the chat if anybody has a thought for it. But just rapidly looking at it, you can, I usually, my eyes, when I want to know what the tag is, I go to see the flow. And as you look at the flow, there is no shape that it's identical to the other. I mean, there's not a geometric shape, a square or a triangle or a sine wave that is identical amongst them. And the tidal volumes are all over the place. So that immediately takes out the possibility of this being a pressure control.
You mean volume control?
Sorry.
You said takes out the possibility.
Takes out the possibility of, I'm sorry, there's stuff appearing on my screen, of this being volume control. So it immediately becomes pressure control. Thank you, Rob. There was stuff appearing on my screen that was diverting my attention. So pressure control, and then the hardest thing when you read this waveform is to try to figure out if this is CMB or IMB or CSB. And I mean, that's why I just simply left the mode over here, which Ariel rapidly tagged as CMB. But Rob, if you would look at this, how could you make out that this is CMB?
Well, I guess what I would do is, after having looked at the flow waveform, I would look up at the pressure waveform, and I would confirm that it's probably pressure control, because we see 1, 2, 3, 4, 5, 6, 7 breaths that are pretty much the same inspiratory pressure. And they also appear to have the same inspiratory time. And what's happening in between is distortions of that. So I would guess that this is not CSV and probably not IMV. So my best guess would be CMV, because every breath appears to be a distorted mandatory breath.
Absolutely. Yeah, I agree with that. It's just that I time seems to be there, but there's so much noise in the signal. And as we have said before, and this is a important statement, remember, ventilators are very good at controlling flow when you put them on volume control, but they're mediocre at controlling the pressure. And it's not lack of love or lack of design. It's just simply it's challenging to try to control the pressure throughout the system. So if we think about the load, what do we think it is? Elastic, resistive, or PMOS? Can we even make out if this is elastic and resistive? And because we're on pressure control, we would look at the flow waveform and see how fast it returns to baseline. But I am forcing myself to see one waveform that looks passive, and I don't see any passivity here. So I think that the loading is PMOS from here to everywhere. Any disagreement there, Rob?
No, I would agree 100%.
Yeah, so a lot of PMOS everywhere. I mean, this is PMOS galore. And then the issue here is, how do we even rate these as we go through the PV discordance? And we usually go by trigger, inspiration, cycle, expiration. But if we look at, there's so many breaths and so many action that it's easy to get confused, right? So I thought that a good way to do this is to go in order at the beginning, and then I think if you can read the first breath, the rest of the breaths would become very evident to all of us. Okay. So as you have seen on many of our SEVA teachings, is that there's breath markers for the activity of the patient, or signals that the ventilator says this was triggered by a signal that came from the patient. It may not be the patient, but it's interpreted by the ventilator as that it triggered either the pressure, as you see here, by putting in this ventilator on the color yellow, or if it was pink, it would be highlighted in pink and it would tell us that it's flow. Or if it's blue and this ventilator has that software, it would be IntelliSync. So this is the marker, and we also see here a mark of it, which is the pressure drops. It seems that the exhalation is happening and then the pressure drops. And in the flow, I cannot see much. It just seems to cross straight from exhalation to inspiration. So I would say that this is a true trigger event by itself, and it's actually pressurizing the system. Rob, any disagreement there with this breath?
Nope.
No. And I'm just going to make it big for 1 second so that we can see what I was pointing at. It's this little drop that we're seeing. This is a triangle, and you can see how this crosses immediately. Okay. So now that we have seen that, oh, shoot, sorry, there. Now the next thing that we look is at inspiration. And when we look at inspiration and the inspiratory phase, I would say the trigger is normal for that first breath. It just triggers immediately. And then I see inspiration and I look at the flow waveform because we're controlling the pressure. And the flow goes up and then it comes down relatively rapidly, but there's nothing there that looks like an exponential decay. It actually looks like a patient that is doing spontaneous breathing, which is a sine flow wave. But then after it finishes inspiration, you can see that the I time continues. I mean, the breath is going to cycle all the way over here. So before I go into that, I will go into it because it's happening during an inspiration, but you see the flow go up. And then actually on this image, you can see how the flow crossed the baseline and it's below the baseline. And because it's below the baseline, that means that this patient is exhaling, even though the patient is getting positive pressure from the breath. So this would be inspiration, but the patient is exhaling through it. Rob?
Yeah, and when that happens, you have to be careful because the displayed exhale tidal volume could be incorrect. Because they're going to be jumping around all over the place anyways.
That's a great point. So not all the ventilators calculate the inhaled tidal volume by this value, but they will give you whatever happens by the end of inspiration. So in other ventilators, it may tell you that the volume was this one instead of the peak over here. Correct?
Correct.
Yeah. So I actually, as I saw this, and the patient is exhaling against the inspiratory pressure, would this be considered a loaded breath for exhalation?
Yeah, because the ventilator is trying to push in, and the patient's trying to push out. So you would call it an expiratory loading rather than an inspiratory loading. Yeah.
Yeah. And then we move on to cycle. And now I have pointed here with a little arrow in red where the breath cycled. And you can actually follow that line down and you see how the peak flow increases suddenly. Pook! That little increase means that the ventilator stopped the inspiratory pressure. It goes down and now the patient can exhale more. Whew, right? And so if we call this a cycle, what cycle would we call it? Early, late, or normal? And I think just remember the patient is the reference, so the ventilator cycled later than the patient. So this would be a late cycle, right? Yeah. Excellent. And so now the cycle is late, and then comes expiration, and comes the expiratory phase, and the patient exhales, and then rapidly after it exhales, the ventilator triggers again, so the patient seems to do another effort, inspiratory effort. It pressurizes the patient, keeps now the ventilator. Oh, actually, no. It seems that the trigger, the new trigger, is all the way over here. That's kind of odd. It took that to drop the pressure. So now that we saw this, you can see that it's triggering appropriately on the first breath, but then the patient is having this. The breath is shorter than what we have programmed, the I time that we have programmed, and now it's exhaling. Now it seems that the patient is inhaling again, and it doesn't achieve the triggering pressure that you need for this ventilator. Ariel correctly states, this is a pressure trigger, and so it seems that it takes a while, and now it's a late trigger. You can see how this crossed, a late trigger. The ventilator pressurizes, and the patient said, okay, I'm done, and now it's exhaling again. And now it's inhaling again. The ventilator cycles, the patient is exhaling and now inhaling. So you can see one patient inspiratory effort, another one, 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 and another one. Do you agree with that, Rob? That there's an intrinsic faster rate that the patient has compared to what the ventilator is providing?
No doubt. Yeah, absolutely.
So this is you can now slowly start seeing that the ventilator on the top is telling you, oh, this patient is cool. He's breathing at 22 breaths per minute, right? Because it's using the rate that we're seeing up here. So you can see in this screen, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 breaths. And from the mechanical breaths, we have 1, 2, 3, 4, 5, 6, 7, 8. So much less breaths. That's why the ventilator is counting less breaths. And sometimes if you cannot see it down on the flow waveform, it's probably easier to see it down on this one, on the volume waveform, because it amplifies what you're looking for, right? So now you can see the inspiratory efforts of this patient, moving flow up and volume up for each one of those breaths. And you see that they match. So very, very, very intense. So essentially, there's a complete dissociation between what the patient is doing and the ventilator is doing, and sometimes it matches close enough that it triggers the mechanical breath for this high respiratory effort for the patient. Comments, Roberto?
No, that pretty much sums it up, I guess. Patients got, like you said, there's no synchrony anywhere.
Yeah. So Ariel, I really love what you just put. So just let me summarize, and I'm gonna comment what you just did, because actually it's the next slide that we placed, which highlights probably that's a topic to discuss today as an item. So This is a patient on pressure control, and it's all breaths that get triggered would be mandatory, meaning that they're going to be cycled by the I time, okay? And we see a lot of PMOS. And actually, as we start going over the breaths, we can see that there's an intrinsic rate that it's going really fast for the patient, and then a very slower rate for the mandatory breaths that now and then gets triggered by the activity of the patient, leading to all types of interactions. But one of the concepts that we saw here is that actually the patient is doing some work. Sometimes the patient is exhaling against the inspiratory pressure. So it's suddenly this patient is set up to a pressure support of 8, it seems, pressure support of 10. So the patient is exhaling against 18 actively, sometimes against 8. And so there's a lot of interaction here from the ventilator. And Ariel puts here whatever is happening to the patient at the time, a CMB mode, which has a set TI, or inspiratory time, will make things worse. Why not liberating the TI in favor of a variable one by switching for a CSB mode? So the question here is, if we switch to CSB, in which the cycle time is going to be determined by the patient characteristics, not by the I time, what would happen? So fair, that's absolutely true. The issue, and I know this because the caregiver that Dr. Harry was talking to me, is every time they change the patient to that, not every time, but either they over-assisted or when they went down on the inspiratory pressure, the patient would become very tachypnic. And then it became very uncomfortable for the rest of the team because it was breathing very fast. And so I think that this is an area that caught my attention. So she took a nice picture of the settings, and we have the frequency over here, the inspiratory pressure, the PEEP, the FiO2 is only 30%. But I would highlight that in this ventilator, and this how it's set, because this can be set differently, and I want to check the manual, and if not, please correct me, Rob and Ariel, but you can set the I time by putting an I to E expiratory ratio, which then uses the frequency to calculate the inspiratory time. So if you put a ratio of 1 to 2 with a frequency of 12, from there you would have the expiratory time, and then from the ratio it would calculate the inspiratory time. And you can see here that the inspiratory time then is set at 1.6 seconds. And the challenge here, and please correct me if I'm wrong at all, is that every time the patient triggers, even though we set the I to E to 1 to 2.1, the patient is going to get an I time of 1.6 seconds. And so the patient has a very long I time, which is leading to all these issues. And actually, if you notice on this ventilator gives you the I to E ratio here, and you can see that at the rate that the patient is breathing, it's 2 to 1. And you can see on this one, the image that we took is 1.7 to 1 because the I time is too long and it's very little time to exhale. So Rob, comments here, please.
Yes, I want to just reflect what Ariel said. The IDE time is not what's actually happening if you were to calculate it from the flow waveform. The IDE setting sets the mandatory breath inspiratory time as you have indicated. But what's really happening depends on how fast the patient is triggering. And you can set the background controls, you can set the default settings so that instead of seeing IDE, you will see and set the inspiratory time, and then the ventilator will calculate IDE for you. I think possibly what happened here is that someone said, well, I think a normal IDE is 1 to 2, so I'm going to set that, and not considering what was actually happening in terms of the mandatory breaths and the actual resultant IDE ratio with all the triggering efforts. So I think the key part here is to make sure whatever you do, that if you impose mandatory breaths, then at least have the mandatory inspiratory time reasonable. I think 1.6 is not reasonable for a patient as actively triggering as this.
This makes me think on something, which is I've seen other ventilators in which you set an I to E ratio, right?
Yep.
And the question I had for you is in this configuration of setting the I to E ratio, the inspiratory time is set by the set frequency. But
Right.
is there any mode or ventilator that implements the I to E ratio on a different way, which would be to try to maintain the set I to E ratio, in which it would adjust the inspiratory time to maintain that based on the prior one?
Yeah.
Does that exist?
It did exist at one time. I think it was GE made a thing that did that. Didn't last very long, wasn't very popular, but yeah, that was a targeting scheme one time. I don't remember exactly the name of it at this point, but it would do that.
I see a comment from Ariel.
Yes.
Go ahead, Ariel.
In order to keep the same I ratios, like the vent has to see the future ahead, because every increase in respiratory rate will have to be with a concomitant reduce on the I time, and it's very hard to keep the same I ratio. I would say that that's a mistake we commonly incur by thinking that A ratio is going to be always maintained, and that's a real problem.
Absolutely, and this was actually a comment. I was in a conference this Friday for the Mexican Society for Anesthesia, and we were talking. One of the presenters was talking about the anesthesia machines, and the fact that, and I presume that this somebody was saying that this has changed, but for majority of machines that they were using, you would set only the I to E ratio. You didn't set the I time on that group of machines. Were you aware of this, Rob or Ariel?
No, and again, I would bet that whatever machine that was, you could change in the configuration to go back to setting the IDE. Another way to think about the way this ventilator is set up and configured is that IDE ratio of 1 to 2 is only valid for a passive patient.
Yeah. I love that. That's a great manifestation. So once that the patient becomes active, what you would have is this patient essentially with loaded breaths throughout, right? So this, and we have talked a lot about under assistance and the presence of loaded breaths on patients that are on volume control, but we have not talked about actually expiratory work or loaded breaths during expiration that may happen because of late cycle or other per se. So interesting. Well, I think that this was I want to again thank Andrea and the group at the Hospital ABC, Centro Médico ABC in Mexico City for the image and for hosting me and chatting for a good morning of learning. Here is the CME for CCF caregivers with Eduardo. The code. Yes, Ariel, go ahead.
Can I say something just to finish? You know, sometimes we have our vents when they come from bioengineering with a set I ratio. And the only thing we can do at bedside, if you don't want to liberate the I time, is readjust the I ratio to try and be just focus on the I time and try to match the patient's neurologic time to the set inspiratory time. That's the only thing we can do.
Yeah, you actually make a great point, Ariel, because I was thinking in my practice how I would live with an I2E ventilator, and it took me some time that this is a hindrance because it may give you a false assessment of what you're actually going to do. But if the patient is completely passive and it has a high resistance, then it may make complete sense, right? It helps you visualize what's the I2E ratio. But otherwise, I think that setting the I time is an easier concept to grasp than the I2E ratio. All right. Well, with that, I want to thank all everybody. Thank you, Rob. Thank you, Ariel, and everybody that logged in today. We appreciate your time and hope that you have a great weekend. Bye-bye.